Okay, so I would like to thank the organizing committee for this wonderful meeting. So we're going to discuss the cervical spine, mainly the subaxial vertebral body fractures. We are talking about the teardrop and burst fracture. So the classical teardrop fracture was described by Schneider and Khan, and is often mistakenly difficult to distinguish between these two types. However, the main differences coming in two factors: the mechanism of action of trauma or injury and the spinal canal involvement. So the mechanism of injury for the teardrop is mainly a compression forces in a flexed spine, while the burst fractures result in vertical compression fractures in a normal lordotic spine position. And that's why can create small changes. And also regarding the spinal canal involvement, we can see the burst fractures, the retrobulging of the fracture fragments, it's exactly at the level of the vertebral body, whereas the teardrops slips posteriorly just at the level of the intervertebral level. So slightly it slips posterior and below to reach the spinal canal. However, still, it is sometimes difficult to distinguish, especially if the vertebral body split or become accumulated fractures. However, the philosophy of management is still the same for both types. This is an examples of burst fractures and teardrop fractures. It can range from simple mild injury with mild neurological manifestations to severe devastating neurological deficits. This is an example of a patient who presented with after a motor vehicle accident. He has a neck pain, mild radiculopathy at the level of the C5-6. We can appreciate from the MRI scan burst fractures with the failure of the superior end plates, a little bit posterior mild retrobulging causing a mild mass effect on the spinal cord with the signal changes on the cord. On the other hand, below we can see a significant unstable, which is we can consider it like stage 5, a teardrop with a significant retrobulging and displacement of the fracture type into the spinal canal, causing significant mass effect. So we can appreciate here the range variety of neurological presentation and the range of biomechanics and stability of the spine in these types. So again, and this is an axial cuts. It can slightly differentiate between the two types, the teardrops and bursts. So the burst fractures, you can hear it's a retrobulge or retro-protrude into the spinal canal at the level of the vertebral body, whereas the teardrops is protruded just slightly at the level of the intervertebral level, which is common in terms of corners. A wonderful study of 100 patients with the cervical spine fractures who was having triangular vertebral body fragments. They found, as we expected, the most common is the anterior inferior corner by most of the 3/4 of the patients, where the least one is, as expected, the posterior superior corner, less than 1%. Another difference between the teardrop and burst, so the burst is very common at the level of the cervico-thoracic junction, mainly C6 and 7, while the teardrop is common at the C5 vertebrae. What is the mechanism of action for the teardrop fracture, or we call it the compressive flexion injury? It is basically a compressive force vector in a flexed spine. And if that force is so excessive and extensive, it can cause further force into anterior and posterior, where it will split the vertebral body, and the anterior inferior corner will go anteriorly, and the posterior inferior corner will protrude into the spinal canal. And whenever we saw a protrusion or retrobulge of the posterior elements into the canal, that's almost always a sign of discoligamentous complex disruption. and it signify a high energy or unstable injury. Again, there is a wonderful description and classification which done by Allen, where he divided the compression flexion injury or the teardrop into 5 stages, 5 patterns, and ranging from stage 1 to stage 5. And that's based on the status of the posterior elements, whether or not there is a translation, and the compromise of the spinal canal. So we can see the stage 1 is only affecting the superior endoplates, mild kyphosis. However, there is no involvement of the posterior elements, no translation, and no retrobulgence, so no spinal canal compromise. Stage 2, more kyphosis with more involvement of the 2 endoplates, and it gives you the appearing or peaking appearance, okay? However, still, there is no involvement of the posterior elements, no translation, spinal canal most of the time is patent. Stage 3, this is we consider it the beginning of the most serious or the more unstable fracture, where the classical teardrop, and there will be some sort of translation and involvement of the posterior elements. Stage 4, it is defined by displacement posteriorly to the spinal canal, however less than 3.5 millimeter. Stage 5, where the displacement is so significant associated with the spinal canal compromise because the translation more than 3.5, and of course there is a disruption of the all posterior elements. We define the posterior elements or posterior disco-ligamentous complex, which associate, including the anterior longitudinal ligament, posterior longitudinal ligament, disc, facet capsule joints, plus the intra and supraspinous ligaments. So whenever you are evaluating such injury, you need to look carefully to the MRI and evaluating these soft tissues. Signs of disruption of the posterior ligamentous complex, including increasing the interspinous distance, separation of the facets, subluxation, loss of parallelism, and kyphosis. And there is a certain numbers of kyphosis. Some they took 40 degrees of the kyphosis as a significant signs or signifies signs of instability. The other stages of or the description for the burst fracture, they describe it in 3 stages. Stage 1, failure of the superior endoplates. Stage 2, failure of the both endoplate, superior and inferior. And both stages can be considered as a stable fracture. Whereas the stage 3, there is a complete failure with the splitting of the vertebral body. So these stages is basically based on translation, the status of the posterior ligamentous structure, and whether or not there is a retrobulgent fractures. So very important to assess the stability and the neurological status, which can be reflected by the presence or not of the retrobulgent fractures. Again, the mechanism we said, as we described it, the burst is a result from axial direct forces on a normal lordotic or normal neutral position of the spine. The outcome, how usually these patients presented? So they presented based on the severity of the fractures. Okay. However, in a study by Lee, he found that 57% of all patients presented with the teardrop, which is stage 3, they presented with quadriplegia, and only 13% were neurologically intact. Another study done by Fisher, where he found same percentage or same numbers, which is 56%, they presented with quadriplegia, and 31% they have a significant weakness. And the most common presentation of weakness, if the patient presents with neurological deficits, they will be presented with anterior spinal cord syndrome, and that can be explained by the anterior mass effect of the retrobulgence, also may affect the anterior spinal artery circulation there. So management. So the aim of management simply is to restore the stability and the alignment of the spine and to decompress the neuronal structure. By this way, we want to offer the best possible chances for the patient to get rehabilitation and to reach the best functional status. Even in completely paraplegic patients, we know the early decompression will not regain fully the functional status. However, it proves it at least will improve the neurological outcome for 1 or 2 levels below the injury, and also it will prevent the surgical intervention, will prevent late complication like post-traumatic syrinx, etc. So instability, let me quote this from White, where he stated the definition of stability is the loss of ability of the spine under physiological loads to maintain relationship between vertebrae in such a way that there is neither damage nor subsequent irritation to the spinal cord or nerves roots, and in addition no development of deformity with excessive pain. And this is very important. This is our main objective or aim from treatment, is to restore stability and to decompress the neuronal structure. So in order to identify the stability, there is many elements you can check it, many criteria you can follow it. However, generally speaking, this is a nice checklist, again described by White and Mijabi, where they evaluate the status of the anterior elements, posterior elements, the translation, rotations, neurological deficits, and based on this, they will decide whether the spine is stable or not. Again, the treatment is dictated primarily by the neurological status of the patient, the stability of the injury, and the extent of canal encroachment. When you're going to treat or management, conservative management can be considered in mild type, which is stage 1 and 2, and those basically if there is no ligamentous injury, no significant kyphosis, no significant translation, no significant retrobulging, and of course the patient will be stable. If you have these criteria, you can manage the patient conservatively by applying a hard collar or a halo for usually 12 weeks. A halo is a good option, mainly for stage 2, or if you have a concern of stability. However, and it's also useful for reduction of the risk of late kyphosis in compared to regular or rigid collar. However, it's associated with other complication for especially in geriatric age group with the skin breakdown and respiratory problem. Of course, the end point for treatment, whenever you have a good fusion and good stability in flexion extension X-ray. Operative treatment, the anterior approach is ideal. It gives you the chance to decompress the neuronal structure and to provide a fusion at the same setting from the same and the same approach. Combined approach is recommended for if there is any severe posterior ligamentous disruption, poor bone quality, and if there is significant deformity. There is a lot of literature where it supported surgical treatment over conservative management. And the surgical treatment provide a superior decompression in compared to the conservative management. And it is safe and effective. Also, they compare between surgical treatment and halo, and they found the surgical treatment is superior to halo in terms of maintaining the sagittal alignment and minimizing the treatment failure. But again, you have to tailor your approach and management according to your patient and according to the stability and neurological function and the type of injury. Also, we found in the literature some comparison between posterior and anterior approach. A nice article where they found the anterior decompression can restore the spinal canal diameter by 60% in compared to the posterior approach. But however, again, posterior approach is still valid in some selected cases, especially in the younger age group, where the alignment is aligned and just to monitor for fixation. I will conclude with this slide. This is a novel technique where they do not do corbectomy and they approach the patient anteriorly and they just do discectomy above and below. And they do one screw in the fracture site. It has to be purchased by cortical. However, this approach, they recommend to use it in two things: if the patient neurologically intact, okay, and if the fragment is anteriorly displaced, not posteriorly, okay. And thank you.